Before beginning, I would like to impress upon the fact that the sleep is a universal function of living species and it comprises one third of the human life. So we should be amazed by the fact that suppose a person lives up to the age of 75 years, about 25 years of the life would be spent in sleep. And poor or insufficient sleep has been associated with a wide variety of dysfunction in most body systems, including endocrine, metabolic, higher cortical functions, and neurological disorders, as well as cardiovascular disorders. So, as physicians, we have to be aware of the chronic effects of poor sleep and the medical conditions such as hypertension, diabetes, and other disorders that are associated with it. And before proceeding further, what are the consequences of the sleep disruption? As we can see, a disrupted sleep leads to various physiological effects, such as increase in the catecholamines, increase in cortical secretion, various hormonal imbalances like increase in the ghrelin, decrease in the leptin, and ultimately all these physiological effects, they culminate both in the short term, leading to the short term as well as long term consequences, especially the hypertension, cardiovascular disease, cerebrovascular disease, type 2 diabetes mellitus, which are commonly encountered in the clinical practice. And these disorders in themselves, they lead to sleep disruption. And here we can see this, how this leads to a vicious cycle of sleep disruption, leading to medical disorders, which further complicate the sleep of the patient. And how to screen for these patients? They may be coming with hypertension, diabetes, headache, migraine, diabetes, metabolic syndromes, and OSAs. These patients, they usually present with symptoms such as excessive daytime sleepiness, non-restorative sleep, morning headaches, intellectual changes. These patients may be coming with infertility issues, men presenting with erectile dysfunction and nocturia. The bed partners, they may complain about their partners with snoring at night or choking or witness apneas. And all these symptoms should be typically screened. We should ask these patients for all these symptoms. And other symptoms could be of insomnia. Patient often report dissatisfaction with their sleep, either with sleep onset or maintenance of their sleep. And insomnia is usually defined as the patient presents with daytime symptoms of sleepiness or impaired attention or mood disturbances for at least 3 nights per week for more than 3 months. And the patients may also present to our OPDs with restless leg syndrome, with presentation of unpleasant or uncomfortable urge to move the legs, which frequently occurs during periods of inactivity, particularly in the evenings, and transiently relieved by movement. And so these are the various group of symptoms which we should screen in our patients in our routine clinical practice. Now coming to one of the common medical disorders, I will begin with hypertension. It is a key preventable risk factor for cardiovascular disease and known for all-cause mortality worldwide. And in addition to factors such as diet and physical activity, it has been found that short sleep, shift work, as well as OSA, they are associated with increased risk of hypertension. And in one of the studies by Gartenberg et al., they studied, it was a cross-sectional study of about 700,000 people. They found that not only short sleep of less than 5 hours, but as well as long sleep of more than 9 hours was associated with increased risk of hypertension. And so every effort should be made to identify and treat the sleep disturbances for not only prevention and as well as management of hypertension. And in one of the meta-analysis by Lee et al., they found that the risk of hypertension was reduced by 0.327% for every 1 hour of lengthening the sleep time. And this benefit was seen for the patients they had different cohort of groups, and this benefit was seen only in the cohort when they compared less than 5 hours of sleep with the 7 hours of sleep. And this is the this is the possible mechanism underlying the sleep disturbances with hypertension. Here we can see that the short sleep duration, shift work, and OSA, they lead to chronic intermittent hypoxia, leading to sleep fragmentation and nocturnal arousals, leading to disrupted autonomic balance. Ultimately, the other things that we find here is hormonal imbalance, as previously explained, that leading to increased ghrelin and decreased leptin, and eventually leading to obesity, metabolic syndrome, and type 2 diabetes. And here we can see that ultimately leading to hypertension. So this is the bidirectional association between the sleep disorders and hypertension. One of the other things is that many patients, they present with resistant hypertension, in which at least 3 different antihypertensives are needed. And despite that, we may not be able to achieve the control. And hypertensive patients with OSA, it has been seen that they have a significant incidence of attenuated nocturnal BP fall. That is a normal physiological fall that is seen. It is not attenuated in these patients. And one of the largest sleep cohort by the Wisconsin group, they demonstrated a significant association between OSA and nocturnal BP non-dipping. That is, BP was not falling in the patients with severe OSA. And in one of the RCT by Walia et al. Group, they found that the severe OSA patients had higher prevalence of resistant hypertension, 58.3% versus 28.6% compared with the patients with moderate OSAs. Now, coming to the heart failure, the patients with heart failure, they commonly present with various sleep problems like short sleep time, low sleep quality, and sleep disordered breathing. Approximately 33% of the patients with heart failure, they can have insomnia, and they can either present with difficulty in initiating the sleep as well as difficulty in maintaining the sleep. Sleep disorder breathing, which includes both OSA as well as central sleep apnea, is in common in patients with heart failure. The prevalence of OSA, it ranges from 20 up to 60% among the heart failure population, compared to around 10 to 15% seen in the general population. The chain stroke breathing, it is also common abnormal breathing pattern observed in the individuals with heart failure, and it can co-occur with CSA. It is a classical pattern of crescendo and decrescendo breathing seen in the patient with heart failure. And CPAP, continuous positive air pressure, has a beneficial effect on the LV ejection fraction, and is currently the best treatment option for OSA patients with heart failure. This is the pathophysiological mechanism. Here we can see that the reduced sleep reduction and fragmentation, along with intrathoracic pressure swings that is seen during the airway collapse during the night, leading to cyclical hypoxemia and reoxygenation, leading to insulin resistance, sympathetic nervous system activation, endothelial dysfunction. All of these mechanisms have been believed to lead to heart failure in the patient with sleep disordered breathing. Now, coming to the CKD and sleep disorders, we may have many patients of CKD or end-stage renal disease who, apart from having their renal problems, they may present to our OPD with sleep-related disorders. A systematic review of 17 studies in patients with end-stage kidney disease found that the sleep disturbance was one of their common symptoms, with a mean prevalence of around 44%. And the commonly encountered sleep disorders in these patients included insomnia, around 19 to 71%, excessive daytime sleepiness, 31 to 86%, sleep apnea in 50% of the patients, restless leg syndrome in 14 to 57% of the patients, and periodic limb movement disorders in 50% of the patients. And here this is in one of the systematic review, it was found that as compared to the prevalence of sleep apnea of around 10 to 15% in the general population, the prevalence can be as high as 40 to 45% in CKD patients, and around 55 to 61% in the patients with end-stage renal disease. So it impresses upon the fact that all the end-stage renal disease as well as CKD patients, they should be screened for common sleep disorders. Now, the bidirectional relation between sleep apnea. Here we can see that the OSA, the commonly encountered sleep-related breathing disorder, through the effects of hypoxia due to airway collapse during sleep, and the other effects that we have previously seen, like hypertension, increased sympathetic nervous activity during sleep, and other pathophysiological mechanisms, they ultimately lead to CKD. Whereas on the other hand, we can see that the end-stage renal disease, by causing increased chemosensitivity, hypervolemia, the rostral fluid shift during night, and by other probable mechanisms, leads to OSA and central sleep apnea. So one disease leads to another, and this is the bidirectional relationship between both of them. Now coming to the thyroid function and sleep disorders, the disturbances of hypothalamic pituitary thyroid axis, such as uh, altered thyroid function or abnormal TSH levels, they affect the arousal promoting system. It has been studied in one of the studies by Stern et al. They assessed 137 patients with Graves' disease and reported the 66.4% of study participants had difficulty falling asleep in that study. And the elevated levels of thyroid hormone are associated with several components of sleep dysfunction, including prolonged sleep latency, difficulty in maintaining sleep, and excessive daytime sleepiness. And specifically the thyroid hormone mediated changes in the appetite, bowel movements, mood, they were associated with prolonging the sleep latency. Now, as we have seen, not only hyperthyroidism, but the hypothyroidism also has an association with insomnia. The patient with thyroid hormone level, uh, with low thyroid hormone levels or even subclinical hypothyroidism, they have longer sleep latency, shorter sleep duration, lower satisfaction with their sleep quality compared to the euthyroid individuals. And underactive thyroid is associated with muscle joint pain, cold intolerance, increased anxiety, and these symptoms can contribute to the sleep deficiencies. And excessive daytime sleepiness and fatigue are one of the frequent symptoms seen in hypothyroid patients. Now, coming to diabetes and sleep disorders, as we know that diabetes is one of the becoming more and more prevalent by each passing day. And American Diabetes Association in 2023 guidelines, they had made a recommendation for screening every patient of diabetes. They have said that we have to consider screening for sleep disorders, health in people with diabetes, including symptoms of sleep disorders, disruptions of sleep due to diabetes, symptoms or management needs, and worries about the sleep. And difficulty in initiating sleep. In one of the studies, were found that the patients of type 2 diabetes mellitus, they had difficulty in initiating sleep, and this risk was increased by as much as 55%, whereas the difficulty in maintaining sleep increased its risk by 74%. And acute sleep deprivation also leads to insulin resistance state. And acute sleep deprivation, whether total or partial, is associated with an elevation of evening cortisol concentration. Sleep apneas are also more commonly seen in patients with diabetes and correlate highly with obesity. The prevalence of OSA in the population with type 2 diabetes mellitus can be as high as 23%, and the prevalence of all various sleep disorder breathings may be as high as 58%. And in one of the trials, the prevalence exceeded even 80%. So various comorbidities that can contribute to poor sleep in the patients with diabetes, as we can see here that OSA, restless leg syndrome, or peripheral neuropathies, all these comorbidities should be screened and addressed in these patients for improving their sleep health. Now coming to even many patients, they may present to the neurology OPD with headaches that may have a component of sleep disorder related to them. The migraine with and without aura, cluster headaches, and hypnic headaches are each reported as intrinsically related to sleep. The poor quality and poor duration of sleep could be one of the triggers of migraine attack. And during cluster headaches, even patients report a poor quality of sleep, which correlates with the amount of daylight. The hypnic headaches is a very rare primary headache, which is characterized by recurring attacks developing only during sleep. And one of the hypotheses is that there is a potential role of obstructive sleep apnea in triggering these nocturnal attacks of hypnic headaches. Now coming to the obstructive sleep apnea, the global estimates suggest that around 936 million people worldwide with mild to severe OSA and 425 million people worldwide with moderate to severe SA between ages of 13 and 69 years of age. The symptoms of obstructive sleep apnea include nocturnal symptoms such as habitual snoring, nocturnal choking, nocturia, restless sleep, GRD, erectile dysfunction, headaches upon awakening, as well as daytime symptoms of excessive daytime sleepiness, memory loss, irritability, depressive symptoms, fatigue, lightheadedness. And all these symptoms, when we encounter when we screen for these symptoms in the patient with medical disorders, then we can use certain risk questionnaires like Berlin questionnaire, Stop, Bang, and NOSAS to assess whether we need to do the polysomnography, which is considered to be the gold standard for the diagnosis of obstructive sleep apnea. Now, Stop Bang score, as the mnemonic says, it has 8 variables. First is the snoring, tiredness, observed apneas, and blood pressure. And the other variables include BMI more than 35 kg per meter square, age more than 50 years, neck circumference more than 40 centimeters, and male gender. If at least 3 or more, if we have 3 or more, if 3 or more variables are present, then patient has a high risk for OSA, and the patient can be further diagnosed for OSA using polysomnography. Now, what is the various pathophysiological mechanisms for OSA? This is the normal airway anatomy. Here we can see the retropalatal region and the retroglossal region. And one of the very anatomical variations can predispose a patient to OSA, which includes elongated soft palate. Here we can see elongated tongue fat and inferior hyoid position with a downward angle of genohyoid muscle, as well as shortened mandible length. Now, what is the overall pathophysiological mechanism? How OSA leads to various other manifestations? The patient with OSA, they have repeated cycles of upper airway obstruction during sleep, which leads to frequent sleep fragmentation as well as arousals, with recurrent hypoxia as well as reoxygenation, as well as recurrent intrathoracic pressure swings with fluctuations in BP and heart rate. This eventually leads to various physiological effects, and eventually it culminates as various clinical consequences such as atherosclerosis, hypertension, erectile dysfunction, MI, excessive daytime sleepiness, metabolic syndrome, impaired renal function. And what are the diagnostic modalities that we have for this obstructive sleep apnea, which is getting diagnosed more and more these days? First, we have behavioral interventions like weight loss, exercise, as well as sleep position restriction using pillows. Then we have medical devices such as PAP devices and mandibular repositioning devices. And then we have surgical procedures which are done on case-to-case basis only, which include uvulopalato-pharyngoplasty, maxillomandibular advancement, hypoglossal nerve stimulation. Now, for screening as well as diagnosing, as we earlier encountered that the Stop, Bang, NOSAS, Berlin's questionnaire, they can be used to screen for the patients who have at high risk of having sleep disorders. And the other clinical tools that we have in sleep medicine include polysomnography, which is considered the gold standard. Then we have home sleep apnea testing, which includes type 2 to type 4 sleep studies. Then we have sleep logs, which can be used to see the sleep hygiene of the patient, not only and then we have actigraphy. Then we have studies such as of airway morphology like CT, MRI, drug-induced sleep endoscopy. And this is just an example hypnogram where we can see the different stages of sleep. Here we can see the N3 stage of the sleep, then REM, and then the other parameters like snoring. Then even we can see the desaturations. This is just an example of a sleep log taken from American Academy of Sleep Medicine. Here, a patient just maintains a weekly sleep diary. The patient puts the day of the week, the type of the work, the type of day that the patient is at work or school or taking a day off, and then the time of the day the patient is exercising, taking alcohol, or going to sleep, etc. And now coming to the end, this is our state-of-the-art sleep lab, which is run by the Department of Sleep Medicine, Department of Psychiatry, as well as Department of Pulmonary Medicine. And here we have 3 polysomnographic machines. And I request all of you to screen more and more patients and send them to us so that they get diagnosed properly in time, and then they can be managed properly. Thank you. I would like